So Natasha Roger will manage the podium in a different way because now with Jacques, we had the idea to organize the LINNC Masterclass at LINNC Paris. So what does it mean? You know that during winter time, with Jacques, we had the idea to offer those LINNC Masterclasses, which were a brand new concept, which the concept was an interview of masters in the specialty, usually 2 to 3 masters. And Jacques and I, we were behaving like a journalist, and we were just teasing questions, triggering problems and questions. So we found that very informative, and it is known that the 15 master classes were a huge success with a lot of people. More than 110 countries were following live the session, which are available for free on the LINNC online platform. So we want to push a little bit this concept, which has never been held in any kind of meeting. So this is a trial, a new way of thinking. So I'm very pleased to welcome Sheldon Eitner. He is not a physician, and he will be dealing by his own those interviews with those masters in our specialty. Thank you, Sheldon.
Well, thank you.
Italo, where are you, my friend?
Over there. He's just to the left.
Okay.
Italo, can you come?
You have to
While
move.
they're moving people,
The scenography is important, huh?
as you heard, I'm absolutely an expert in nothing. And that's why I've been chosen to be here, so we can have a discussion, but also we have very little time. So we're going to try to wrap up everything that's happened in the last 2.5 days in 30 minutes. And we're going to talk on 3 subjects, and we'll begin right away. I'll begin by asking Ricardo Hanel to talk about his reaction to what we've been speaking about in terms of aneurysms here.
I cannot start without saying thank you to Jacques and Laurent. We know how hard they pushed to make this happen in the middle of COVID crisis. So I think that's, for me, highlight number 1. It's great to be among friends and to see people and interact. I think it's fun in the room, it's fun outside of the room, it's fun to see friends and be among great people. I think seeing the variety of treatments for brain aneurysms that we saw here over this last 2-3 days, used to be that we didn't have great tools. Now we have phenomenal tools. A garden variety, for me, highlight. Again, the curve that Laurent did on that pica aneurysm, I think that was pretty impressive. Mini-me, I think that's the way to go. The case that Jacques showed with the web and manipulation of the web to seal that neck, the contour case, I think those are the highlights from the technical aspect. I know some people they don't believe on the robotics. I think Victor was brilliant in showing and demonstrating that this is just the beginning. A wise man once told me, never bet against technology. We see where we are in terms of interventional neuroradiology, neurology, neurosurgery today because of technology and masterful hands behind that. So that for me is the 2-minute summary of LINNC 2021. Thank you for the invitation.
Yeah, but just a quick question. Speaking for me as someone who knows nothing, but is probably typical of the patients you see. I know a little. I've just heard you talk about a lot of devices. Is there any way you would explain to me why you would choose one approach over another, or I have an aneurysm of some size and you would choose to treat that? What would you say to me?
I think I would tell my patient, my lay person in front of me said, in 2021, we have great options. It used to be that maybe we didn't have a good answer for your problem. Today, we may have more than one good answer. So I think technology helps what it should be for each one of us. Treat that person that comes through our door. So I would tell the patients, you have better options today than you had 5 years ago.
And if I have an unruptured aneurysm and I don't know it, how would you convince me that it should be treated?
That's a case-by-case discussion. I think we had a super nice discussion on that. Adam showed us some data. I think you have to look at all kinds of characteristics of the aneurysm and individualize care for each person. There are aneurysms that are better left alone, and sometimes it's hard to convince people because the concept of ticking time bomb, and we should deconstruct that, but there are patients that deserve to be treated, and we are better today than we were 5 years ago. So the treatment today is safer than it was 5 years ago, in my opinion.
Are there any medical approaches, or should I be worried about dual antiplatelet therapy afterwards? I'm the patient, I'm scared, I've read too much.
So I do use, there was a subgroup, there was a study done on ISUIA patients taking aspirin or not that was published a couple of years ago by David Hassan with the ISUIA group from Mayo. All my patients that I don't treat, these patients take a baby aspirin. I think it makes a difference psychologically because they feel like they're doing something. And we have okay data, it's not great data, it's not randomized data. I don't think we're gonna get there. For randomized data for unruptured anesthetical treatment, I don't see us there. But I do use aspirin. I think it's a pretty safe medication.
And what are you expecting from LINNC 2022?
Always more. I know we're going to do better. I think it's phenomenal to be here and to exchange information and learn from each other. I can only. I'm looking for LINNC Miami actually. That's coming next.
That's very fast upon us.
But it's phenomenal to be here.
And just as anybody else on the panel want to make a very quick comment on the aneurysms? Well, then I think we can go on. We're going to do a quick summary of AVMs, and for that I'm going to ask Tudor Joven and Céla Laman. So why don't we start with Dr. Laman on AVMs.
Yeah, I'm again delighted to be here and again seeing people and having a live conference rather than the virtual stuff we did, although the master classes virtually were excellent and very useful. The AVM treatment, the advances is not as much as we had in aneurysms. Obviously, the technology not advanced as much as aneurysms did. But we still have the balloon catheters, the venous access. These are all more recent advancement in terms of AVM treatment, and we saw some of that in this course. I think the future is probably going to be much slower with the AVM treatment compared to aneurysm treatment, and perhaps the robotic work we've seen with aneurysm work is probably unlikely to happen as much with AVM work. Perhaps more work needs to be done on the research side of things in terms of which AVMs we should treat and whether intervention is better than non-intervention. Due to the Aruba study, I think the advancement made in the last few years perhaps justify a further look into the AVM work that we're doing. And maybe things are different right now than they were before. We won't be able to cure AVMs transvenously in the past, but now we can do that in quite a few cases. So further look into that in the future, I think, is probably required. So.
And Tudor Joven?
Yeah, so I must say, you know, one of the things that I took away with respect to AVMs is that, unfortunately, we're probably the overall volume of AVM treatment has gone down, and I'm not sure that that's necessarily a good thing. I think Aruba had made a big impact on the practice of AVMs, and I agree that you know, technology has evolved. This is an old trial. We can't just be stuck in the past. And quite honestly, it was a great effort, but I'm not sure that. I mean, certainly Aruba has its flaws. One can even say that, you know, so it's an example of a bad randomized trial is worse than no randomized trial at all. We have some lessons learned, but the truth from Aruba, but the truth is that this remains, and that's an unequivocal truth, that this remains a condition with a bad natural history, and we can't give up on it. And there are new techniques. We've heard about imaging, 4D imaging, that may again be a revolutionary advance in endovascular treatment. We've heard about the balloons and embolic materials and everything else. What I'd like to understand better with AVMs is to what extent endovascular therapy is in what cases we should only use endovascular therapy and what the role is as standalone versus adjunctive to surgery or radiation therapy. But again, I think that we cannot give up on AVMs just because of Aruba. We need to pull together and generate data and get ourselves out of this hole, because the natural history, we can't go to a patient and say, hey, you're going to have a 2% per year risk of hemorrhage. That's okay. That's the best medical therapy. That's the best thing we can offer you. I don't think we should give up on that line.
You know, it's the same question that I asked before to Ricardo Hanel, and I'm asking both of you. Here I am, the patient. I don't know why I should be treated at all. And when you speak like that, it seems very diffuse. I'm not quite sure. Do you have particular indications that would let me think, okay, I should be treated now? From this meeting, have you learned something that would say, okay, do it now because of this? I mean, I need something solid because I don't know.
I think that the age of, and I think this has been touched at this meeting and in various forums, and that the age of this paternalistic approach to treatment is over. We should engage our patients and give them an honest overview of the data, of the natural history, and engage them, especially in a condition like AVM, engage them in the decision-making process.
Dr. Lehmann, what would you say about that?
Yeah, I think it's case-by-case basis, very similar to aneurysm. Ricardo gave the answer earlier. It's case-by-case. It depends on the age, it depends on the location, the eloquency of the area. So there is plenty of factors to take as to whether we should treat you or not. I won't consider your age in this situation, but I think the younger patients are probably more likely to suffer with this disease long term. So perhaps we are underestimating the effect of AVM untreated on these patients. And I think Aruba probably, I would say, is a wake-up call for all of us. There is an element of bad treatment was going on. And perhaps this resets the clock and make us think more carefully as to what to do with AVMs. So that probably is a positive thing from Aruba, I suppose.
If I could make a quick comment about Aruba, one of the things that happened, I think you should compare Aruba with IMS3 in stroke. Many of the masters of the field refused to participate. This happened in IMS with stroke, was one of the main reasons why IMS3 was negative, right? So what we did after IMS3, we go like, if you really want to rescue this field, we gotta do it the right way. So I would say to the masters of AVM, and I'm not included in that honor roll myself. I enjoy doing it. I do it sporadically. I'm not Jacques. But what I would say to you is, go and grab it. Rescue this field. You need to organize yourself and convince people that this needs to be done. And the only way to do it for the next generations is through a randomized clinical trial, including the best possible treatment that can only be done by few highly specialized centers and people.
Well, I think that the Masterclass touched on several cases of the fear of treating aneurysms after Aruba. And of course, all that information is available to people making a choice, but I suppose you still are treating them. Do you have particular indications or that you're using today, specific indications for treating aneurysm that came out of this meeting or that were repeated in this meeting? And not aneurysms, sorry, but AVMs?
Yeah, I mean, we still treat ruptured AVMs. The Aruba issue is mainly for unruptured AVMs, while ruptured AVMs are still on the cards and we still treat them, whether some of us lean more towards SRS, some more intervention, some surgical. But still, this day and age, we saw a case here where the patient has bled, and the guys in Bussetto decided not to treat it because they've been worried and careful about the approach and decided to go venous rather than arterial. So there are learning points, not just from the technique, but also from the decision making that you can take from this meeting.
Okay. There's no medical approaches, or you want to talk about drugs or anything like that that came up for this? Well, No, so we can
Well,
go
the
on.
medical approach is no treatment. You just
There's no treatment at all.
The medical approach is no treatment.
No treatment. Okay. Well, that's an easy one to sum up. But why don't we move now to stroke? And for that, we'll speak with Atala L'Enfant and Raul Noguera. We'll begin with Atala L'Enfant. Could you tell us a little about what you took home from this meeting?
Well, I echo the remark of my colleagues. Really to thank Jacques and Lorraine and the organizer of this meeting. It's a phenomenal meeting, very unique. They were able to put together, in the middle of the pandemic, a rockstar faculty. Really, I'm really honored to be out of here. I learned so much in the last 2-3 days. So I think the list of things that I've learned is so long. For stroke in particular, they made I like the idea of putting cases in the middle of lectures, because it really kind of breaks the long cases and the long talks. And there's so many. They really touched on the most advanced on this field with the lectures, with this advanced imaging, in the angio suite. I got to save a tremendous amount of time. The results there are amazing. And of course, the neuroprotection treatment by Dr. Goyal, very exciting. We are moving. Expanding the treatment to save the life of many more patients. The case, I think they were interesting because I think that Jacques and Laurent very smartly organized cases to show different type of device and different type of techniques to approach a problem. So the faculty was engaged in their thoughts about different type of techniques and approaches. A very, very smart idea. Created some controversy, some debates, which is always very interesting. So I really appreciate that. And I think I learned a lot.
And well, going back, speaking specifically of some of the things we discussed earlier in stroke, has your way or indications for doing thrombectomy changed in the last 2 years since you were last here?
I think thanks to the work of Raul, Tudor, and many others, now we are expanding the window of treatment. More trials are coming up with low NH stroke scale, so lighter strokes and worse strokes. I think we're really expanding this treatment to many more patients, like I discussed with Jacques this morning. I mean, it's amazing. It's a disease that we are now treating, and a disease that was a few years ago was deadly. I mean, nothing will survive. So many amazing cases of survival. I think the future is going to be smarter and better with new devices, with new medications to expand the treatment, a multidisciplinary approach.
But specifically, you were talking about new approaches, perhaps, in protecting part of the brain after a stroke. Can you speak a bit about that? I heard something about maybe drugs that could help protect parts of the brain that are not...
Well, I can talk for a long time about that because I've been dealing with it for the last 5 years. Yeah, there's several devices. We're really kind of translating. So there's two fields: the basic science fields in experimental ischemia that's tremendously advanced in the last 10 years, and so the clinical side. And actually, which sounds good, but it's actually a challenge because people cannot do both. So it's difficult to see what's going on in the basic science field and keep up with and vice versa. So I think bridging these two huge roads with translational medicine has been really this is the way to go in the future. So we have definitely we're going to have several interesting devices for neuroprotection, or this term neuroprotection.
And this neuroprotection is something that happens before or after the thrombectomy?
Yeah, that's a great question. I mean, we're looking at before thrombectomy because it's the most rational approach. However, we're finding out, like through those lectures today, there's so many things that happen also afterwards. So maybe even afterwards, there's much more room for improvement and give a life free of disability to hundreds of thousands of people.
And that's in addition to dual antiplatelet therapy for afterwards?
Well, we're talking about acute stroke. So
right,
antiplatelet for stroke is mostly prevention. Yeah.
Okay.
For stroke is mostly thrombolysis, and there's new.
So except for people with comorbidities who are already taking.
Yeah, mostly for prevention, or sometimes in acute stroke you have to implant a device, but. Yeah.
Raul Noguera, would you like to give your impressions? Thank you.
Well, first of all, I would like to echo what everybody has said. It's absolutely fantastic to be here, see friends after so long, and it has been really one of the really special moments that I have had this year. It's been way too long, friends. And having said that, I really enjoyed this session this morning. I think we could call it Back to the Future, because we revisit two topics that had failed in the past. One, to review the topic of intra-arterial thrombolysis, right? And I just talked about the IMS3, which was a trial, over 50% intra-arterial thrombolysis, and it failed. The other topic that had failed when you discussed this morning was neuroprotection, right? We've tried it many, many times before. And I'm not so sure that the answer is just because you now may have better compounds. The answer is because we understand that both intra-arterial thrombolysis and neuroprotection may have a role after at least partially successful mechanical thrombectomy. So you are revisiting the past and seeing that things that have failed in the past may have a role in the future. And I think that was very clear in the session this morning. I love the way that this was designed. The other thing that I think the conference highlighted very well is there are many therapeutic advancements that you need to cover in a conference like this, and you can divide them in technical aspects, like what is the combination of devices that you use, but also the technological aspects, what are the new devices that we have there. Here in Europe, you have a lot more devices than we get in the United States. I think the only thing that you haven't here that we have there is the 088, so I'm glad you could have a little bit of a discussion about this today, because again, many of us think that's a really big hope and great help. But again, this idea that the field evolves in two ways, right? Not only through new devices, but also we learn how to better perfect our techniques. And this is something that I think could have been said about AVM, even though you don't have new devices about AVM. The transvenous embolization and all that with devices that you have had now for some time, it's a technical advance in the absence of a technological advance, but it's an important advance that needs to be explored properly in a randomized controlled trial in the hands of the people who know how to do it.
Do you have a reaction to that? Anybody on the panel?
Well, I mean, I echo what Raul says, and I just want to touch upon another condition that I think has been treated unfairly in the interventional world, which is intracranial stenosis. It's another condition that reminds me of AVMs at some level, because its development has been completely hampered by a negative trial that used old technology, old techniques. We have technology that has revolutionized our field, which are these intermediate catheters that make delivery of stents in the brain much, much easier. And just like with Aruba, Sampris has put enormous brakes in the development of this field. And it was great to see that there are some centers, particularly in Asia, where this disease is so prevalent, that are pushing the field forward, and that's very important.
Any comment on that?
I think that's a critical point. Again, we can see how randomized clinical trials can hurt you if they are not designed in the best way. Having said that, it's always easy to revisit the past and see the mistakes, right? It's hard to think about them up front. The only thing I would add in terms of ICAD, it's not only you have better technology and technique, but also you understand a lot better about proper patient selection now than you understood during the Sampris and Visit trial times.
I think that, well, you've spoken a little about what wasn't said at the conference. There was some mention of robotics. There's been all this. That seems to be moving not simply to a question of a new future technologically, but also a new approach to the work. You said something interesting this morning about the time. It gives us a space that we step back a moment. Could you talk to us about again, because it was interesting.
I think when you watch Victor doing that not using his bare hands that he is masterful doing, but using the robot to do that, you can watch the reaction of the coil or the stent or the flow diverter on the way that this is designed to work, because it forced the operator to slow down a little bit. And also, I think, and it was interesting to talk to Raul about that and talk to Victor about his fellows doing that, is not because of his high level of expertise, is the machine enhancing his performance. So that's what I think is going to be very interesting when we can do this in more centers with newer operators doing that. If the machine is gonna short the learning curve for the new operators,
or change the whole approach to the way you approach your intervention. Anybody else have a reaction to that?
I think whoever has done cases with the robot, in the United States you cannot do intracranial cases, but we've done carotid stents, describe a series of those cases. It's very easy to learn. One of the things that I think we all acknowledge now is, I think someone who's highly experienced may have same degree or more degree of fine control, but the average person, probably not, actually. The robot, it's highly, there's a lot of precision, specifically with the going back and forth of the microguide wire, that even good operators sometimes struggle. If you're going to a small aneurysm, you have to seesaw, I don't know how you call in Europe, in the US you call seesaw. It's like a movement of back and forth of the microguide wire and the microcatheter. And sometimes things jump a little bit. And I think because the robot does very fast micro movements, it can adjust better for that than most humans can, mostly in the early phases of their career.
It seems that this kind of technology just is an extension of the hand of the operator. I mean, it can help the movement, but it still depends on the touch. It's not artificial intelligence. It's not something like that. What other unspoken things have occurred? What needs to be spoken about in the next link? Is there any particular topic that we haven't touched on today that you felt wasn't here?
Well, I think there's a lot of new technology coming up. So I think Jacques and Laurent made a good job to try to bring it. But I think this field is really exploding, thanks to them too. So maybe you have a last session. I'm just thinking out loud because I never thought about this. Having a section on the new advancement and new frontiers, perhaps something that has not been. We don't have clear data yet, but there's a few cases done or a few approaches done, and how this can be improved. Maybe something like looking in the future, possible from now.
There are a lot of things to touch on, and at some point the meeting risks, being out of its focus, which is interventional cases. But, I think that there are some conditions that may not have been touched upon as proportional to the rate at which they're catching on in the world. For instance, middle meningeal artery embolization. But in general, I think that we should try to explore a bit all the conditions for which right now we don't have routine treatments, but are very promising, like tumor embolizations, for instance, or implants of stents or devices that monitor or stimulate the brain. These are up-and-coming things for which there are some endovascular solutions. So the field is evolving that fast. Sometimes when you start planning, some of these approaches are not even there. So that
or similar to what Raul Noguera said, you find that old approaches have a new use or a new interpretation. I don't want to harp on the fact that what I am is probably a typical patient or the family of a patient, but it seems to me that also with all this information, all the things you're able to do, yes, you don't have to be paternalistic with your patient, but educating the public like me who has access to too much information and has a hard time judging is also one of the critical elements of the next few years. And I want to thank you for being with us. And we look forward now to the next case. So I'm going to pass the microphone back to Professor Spell. And I appreciated being with you all. Thank you.